Thank you very much, Dr. Flanagan. Good morning, everyone. Good morning, professors and doctors. As Dr. Flanagan mentioned, our topic today is medical population with high risk of sexual dysfunction. Is there an unmet need? Overview, objectives, overview of male sexual dysfunction, overview of biopsychosocial approach to manage sexual dysfunction, discuss male sexual dysfunction in context of cancer treatment, discuss male sexual dysfunction in context of medical population. Male sexual dysfunction is types of it is erectile dysfunction, Peyronie's disease, rapid orgasm or ejaculation, delayed orgasm or ejaculation, retrograde ejaculation, failure of emission or ejaculation, low sexual desire. An overall prevalence of sexual dysfunction, erectile dysfunction in one study of global prevalence, it shows 3 to 75%. In Massachusetts male aging study, they found that 40% of male in their 40s experienced erectile dysfunction, and the prevalence of ED increased about 10% per decade. Peyronie's disease, 11 to 13%. Rapid orgasm or premature ejaculation is 5 to 30%. Delayed anorgasm or delayed ejaculation is 1 to 4%. Retrograde ejaculation, failure emission or ejaculation, unfortunately, there is no exact percentage in the literature have met yet. Low desire is 1 to 20%. High risk population, prostate cancer survivor. In a study, they found that erectile dysfunction is as high as 90%. The pathophysiology or the causes for that after the radical prostatectomies, it could be due to ischemia, neuropraxia, local inflammation, and penile hypoxia. They found that patient age, preoperative erectile function, and comorbidities are independent predictive of postoperative erectile function. There is a difference between the management in randomized controlled trials of active surveillance versus radical prostatectomy and external beam radiation. At the baseline, before starting the management, 67% of men reported good erection or firm erection enough for penetration. At 6 months after the management, the active monitoring or active surveillance, the percentage dropped down to 52%. And for radiotherapy, dropped down to 22%, and radical prostatectomy dropped down to 12%. At 6 years, the active surveillance were 30% of their erectile function, with radiotherapy 27% and radical prostatectomy 17%. Erectile function is worse with ADT. The incidence of venous leak in a study showed the incidence of venous leak within 6 months of surgery was 60% with ADT and 20% without ADT. So sexual dysfunction is among the most distressing side effects in prostate cancer management. Other complications include penile length loss and penile curvature. Length loss of 1 to 3 centimeters over within 12 months have been found in the literature. In a study done by Tal et al. Found that 15.9% they would develop Peyronie's disease in a period of 14 months post-radical prostatectomy. Other complications include hypoactive sexual desire. It's occurring 60 to 80%. The reason behind that is either sexual and or due to hypogonadism. Ejaculatory and orgasmic dysfunction. A study of 239 patients, they found that 22 report no orgasm, 37% report 22% report no change, 37% report complete absence of orgasm, 37% reported decrease in orgasm, 4% reported more intense orgasm. Dysorgasmia was reported in 14%. What's the approach? Biopsychosocial treatment paradigm. Ideal treatment for patients with sexual dysfunction is through biopsychosocial approach. Bio, through medication, devices, and surgeries to gain sexual function. Psycho, through psychological intervention such cognitive behavioral therapy, mindfulness, and other strategies to enhance sexual function. Social treatment recommendation in context with patient partner in optimizing sexual function and well-being. Here in BC, a great program was built with a great effort in a prostate cancer supportive care program. It's a Module 2 sexual health clinic, consists of registered nurse, MD, and clinical counselor available to manage sexual dysfunction. Management approach, either in person or virtual clinic evaluation and management, full spectrum biopsychosocial management approach, educational pamphlets and videos, group education sessions. What about sexual dysfunction and other malignancies? Now we already have awareness of sexual dysfunction, prostate cancer, and it's well studied, and understand the needs and barrier and facilitators. What about the risk of other population, including, let's go through. Bladder cancer, in a study done for 117 patients, mean age of 64-year-old. After transjudicial resection of prostate, they reported that sexual inactivity, 38.8%, and erectile difficulties found in 60%. Worry to contaminate partner with treatment agent found in 23%. In another study of 142 patients, within 4 weeks after diagnosis, sexual active patients were 87, 70 male and 17 female. During the surveillance, ED or vaginal dryness were found in 54%, afraid to harm the partner 23%. In their literature, in their study, they found no risk factor were identified. How about after radical cystectomy? A study consists of 259 patients where 82 underwent radical cystectomy and 177 non-radical cystectomy. Most of them were carcinoma in situ. 89% of radical cystectomy could not maintain erection compared to 32 non-radical cystectomy. In another study of female, showed also sexual dysfunction in female categories. How about the type of the diversion? In a study compared between ileal conduit, continent, reservoir, and new bladder, reduced sexual capacity in the great majority of patients without nerve-sparing surgery, with no difference being noted among ileal conduit, continent, reservoir, and new bladder. However, ileal conduit had worse body image compared to new bladder patients. The type of urinary diversion did not appear to be associated with difference in quality of life. Another study consists of 119 patients, either for continent, cutaneous diversion, or new bladder. Postoperative sexual function decreased equally among both groups. In another study of 146 with ileal conduit and 115 with new bladder, they found that with ileal new bladder have significant better global health status and quality of life, also better physical function. The management of the erectile dysfunction in the for bladder cancer survivor, most of the data was taken or dependent on prostatectomy ED management. However, here there is a study of randomized controlled trials. They were comparing of no management, PDE5 inhibitor, intracorporeal injection with vasoactive medication, and ICI with PDE5 inhibitors. They found that no statistical difference between no treatment and PDE5 inhibitor. However, there is a statistical difference between the PDE5 comparing to intracorporeal injection. Colorectal cancer. In a literature review, it showed that erectile dysfunction and ejaculatory disorder, and also the female vaginal dryness, comparing to general population, is significantly high. And they found that the reason behind that, or the main factor behind that, is autonomic nerve injury during the surgery that cause urogenital and sexual dysfunction during the procedure. A study here comparing the colon cancer and the rectal cancer consists of 468 male with colon cancer and 297 male with rectal cancer. All the modality of sexual category is affected. However, it's higher in the rectal cancer. Erectile dysfunction, ejaculatory problem, vaginal dryness and dyspareunia in the female, it's all higher in rectal cancer. That study concluded that associated variable include higher age, not having partner, low educational level, rectal cancer, depressive symptoms, and fatigue were associated with high sexual dysfunction. In another study, it showed the same. They found that open surgery, stoma, locally advanced disease, and post-op chemo or radiotherapy have higher rate of sexual dysfunction. In a study about presence or absence of stoma, they found that moderate to severe ED is significantly high on patients with stoma comparing to non-stoma patients. Treatment, psychosocial therapy, PD-5 inhibitor, vacuum devices, intracorporeal injection with vasoactive, intraurethral, and penile prosthesis insertion. In a study done for 32 patients with after rectal resection, sildenafil, 80% of the patients recovered their sexual function comparing to placebo. What are the barriers? And there's a study here mentioned about the barriers for prostate, bladder, and colorectal cancer. They found that their barriers are psychosocial. There is psychosocial barriers, okay, in form of depression, anxiety, poor couple coping, loss of masculinity. Barrier in healthcare. Here is a study done in England, UK, of 546 patients with erectile dysfunction after prostate cancer treatment. They found that 21% were not offered any ED management. 23% were not satisfied with the way urologists addressed their ED concern. 12% not told about ED was a risk factor of prostate cancer management. Testicular cancer, here a study conducted for 120 patients after testicular cancer management with max age of 916 control. They found that there is high risk of AD and low sexual desire after 3 to 5 years of management. Sexual function in different management of testicular cancer, they found that comparing to surveillance, chemotherapy and chemotherapy with radiotherapy had higher risk of erectile dysfunction comparing to surveillance alone. Hypogonadism, it's also the same comparing to surveillance. Presence of chemotherapy and radiotherapy were higher in sexual dysfunction compared than those treated with orchiectomy alone. Management. In this study, they conducted 76 patients. 84 patients complained of primary loss of erection, sustainability. All of them they had normal duplex ultrasound. After trial of PD-5 inhibitor, 88% of those patients have erection sufficient for penetration. Lymphoma, a systemic review showed 20 to 54% experienced problem with one or more aspect of sexual function. Here's a study compared between lymphoma and control. Matched age, mean age is 47-year-old. Lymphoma survivor have significant lower brief sexual function inventory and erection, ejaculation, and sexual satisfaction. When it compared the modality of management, they found that chemotherapy have reduced more sexual enjoyment comparing to radiotherapy. However, no difference between the chemotherapy regimen. Are there high risk of medical population? Let's see. Chronic kidney disease prevalence, 70% on average in male and 80% of average on female, they would suffer from sexual dysfunction. What are the causes? Hormonal abnormality, decreased testosterone. Here, a study was conducted to 214 patients with chronic kidney disease. They found that 26% have low testosterone level and 30% have low normal level. Other causes include endothelial dysfunction, comorbidities, autonomic neuropathies, anemia, and drug-related. Management, including PDE5 inhibitors and second line of therapy. Here in PDE5 inhibitor, a randomized controlled study was done to 16 patients, comparing to placebo, which showed improvement of erectile function, intercourse satisfaction. Here is an approach proposed by Palmer. It showed that history, the approach of management include history, physical examination, optimizing delivery of dialysis, maintaining hemoglobin between 11 and 12, treat hyperparathyroidism, and medication. If the patient had decrease in libido, address the potential psychosocial causes, do hormonal tests. If the patient would have low prolactin, start bromocriptine. If the patient is having a low testosterone, only trial for testosterone. If the patient would present with erectile dysfunction, also again should rule out the psychogenic etiology and trial of sildenafil. If no response, there will be second line of therapy like vacuum devices, intracavernosal injection, urethral suppository, surgical management with penile prosthesis. Renal transplant. Would renal transplant improve the sexual function of chronic kidney disease patient? Here is a study done for 63 patients post-transplant. They found that their erectile function improved after the transplant. However, in another literature review, it showed that prevalence among those patients reaching up to 54% to 66%. Does it affect the relationship? In a study was done by Righi et al., it showed that patients would have 25 of patients not interested in sexual activity, and their sexual satisfaction decreased from 74% to 57%. The partner, 23% of them also not interested in sexual activity. Simultaneous pancreatic and kidney transplant. These transplants are consistent for a type 1 diabetes mellitus with end-stage renal disease. Men are at increased risk of sexual dysfunction. Findings suggest that sexual function parameters may benefit from kidney and pancreatic transplant comparing to kidney transplant. However, in another study consisting of 100 male patients, there is erectile dysfunction about 79%. Liver transplant. In the literature, the liver cirrhosis, in the literature review of a liver cirrhosis, 770 patients were examined and found to have approximately 80% of erectile dysfunction. Does the transplant will correct that one? The evidence is mixture, whether the transplant will improve the sexual function. Here in a study consisting of 25 patients, liver transplant improved all sexual function domain. The score of erectile function increased from 21 to 26. However, another study showed that male, they would have 32% of erectile dysfunction, 23% decrease in libido, 33% difficulty reaching orgasm and intercourse. Also, it showed 33% with sexual dissatisfaction. The partner sexual dissatisfaction reached up to 23%. Among those patients, 80% of male and 70% of female seeking medical advice for this problem. Another study have showed that the post-management or post-transplant sexual inactive men decreased from 29% to 15%. However, the erectile dysfunction remained unchanged. They found that the cardiovascular disease, age, comorbidities, comorbidities, and pre-transplant sexual inactivity, alcohol abuse, and medication are associated with erectile dysfunction post liver transplant as unpredictable value. Heart transplant. A study showed that sexual dysfunction among men is 78% and among women is 50%. No significant relationship between sexual dysfunction and mental health or depressive symptoms. Sexual dysfunction is secondary to physical rather than mental factor. Management of transplant organ. It's the same schedule or it's the same management. PDE5 inhibitor, it found that it's improved 60 to 80%. Sildenafil is safe in cardiac transplant patients and have been used to treat the pulmonary hypertension to control the pulmonary hypertension. Intracorporeal injection, success rate of 60 to 80%, as been the literature. Bavvarin might deteriorate the liver function by increasing the enzymes. However, no study conducted on liver transplant patient, but monitoring is warranted. Penile prosthesis insertion. They found in a study between transplant patient and non-transplant patient, the infection rate was comparable. However, the malfunction and injury for the prosthesis is higher in transplant patients, especially due to the reservoir, especially in pelvic surgery. However, with the recent modalities and recent technique, that percentage is decreased. The author suggested a protocol for those patients should have stable graft function for at least 6 months and low doses of immunosuppressants. Heart disease, congestive heart failure. A study showed that erectile dysfunction is as high as 79%, and for the female, lubrication is decrease in the lubrication in 80%. Treatment options was rarely explained or discussed with or initiated with the patient. Here we can see that in these two graphs, the upper graph, they were questioning the patient if have been reached out by their physicians or their treatment team to ask about sexual dysfunction. 75% they answered is none. And when they were being asked to if they want to be treated to improve the sexual function, 60% they would want to be treated. What are the risk factors of underlying reasons? Arterial insufficiency and endothelial dysfunction, increased circulating vasoconstriction such as endothelin, as well as reduction in vasodilators such as prostacyclin. Psychosocial problems such as depression and anxiety, which are common in heart failure patients. Heart failure medication, digoxin, beta blocker, thiazide, and spironolactone. And also presence of the other independent factor. Treatment. Number one of the treatment is lifestyle modification and change of medication that would increase or cause erectile dysfunction or sexual dysfunction, like spironolactone to be changed to epinephrine that is seen to have no effect on sexual function. Change from first or second generation of beta blocker to third generation beta blocker. Specific management of erectile and sexual dysfunction include PDE5 inhibitor. In a study of randomized controlled trial, it showed that is the 74% of the patient improved their erection and 68% improved their intercourse. It was well tolerated, improved erectile function, improved sexual satisfaction, ambulatory subject with mild to moderate heart failure. Other second line therapy include vacuum erected devices, intracorporeal injection, and transurethral or transurethral prostaglandin. Coronary artery disease. Coronary artery disease, in a study done for 300 patient, they found that 49% they would have erectile dysfunction. 67 out of those patients reported erectile dysfunction before the coronary artery disease. In another study, they found that those patients with coronary artery disease, they would have 70% of erectile dysfunction. And they conclude in their study that ED is extremely common in coronary artery disease, yet most cardiologists don't ask about it. Management, here is also management of PDE5 inhibitor. Sildenafil, it shows to be improving the erectile function comparing to the placebo. The side effect is consistent of transient headache, hypertension, flushing, and dyspepsia. However, no serious drug-related cardiovascular effect. Use of organic nitrate are absolute contraindication with PDE5 inhibitor. Other PDE5 inhibitor, tadalafil, also in randomized controlled trial, showed its safety and decrease and no increased rate of MI or cardiac mortality. Other kind of management, intracorporeal injection, it showed its improvement and success rate in 94 and after 1 year, 96% of the patient. ICI may be a good alternative who failed or having a contraindication for sildenafil or other PDE5 treatments. Diabetes. Erectile dysfunction were found in 37% of type 1 and 66.3% of type 2, respectively. It also shown that erectile dysfunction in another study showed that erectile dysfunction between 35% to 90% and ejaculatory dysfunction between 35 and 50% of men. Mechanism how the disease is affecting the erectile dysfunction. The mechanism of this complication is truly affects each step of erection physiology. These include failure of transmission of neural signals to and from spinal cord due to neuropathy, resulting in decrease of neural nitric oxide delivery to cavernosal smooth muscles, also impaired in sinusoidal endothelial cell and decreased release of nitric oxide from the endothelium because of the endothelial dysfunction. Also, there is reduced of blood flow in the arterial and increase the arterial resistance. Also, failure of relaxation of the corpora from the glycation of the elastic fibers. Management. Psychosocial and relationship issues should be identified and addressed in all patients. Glycemic control. In a study, they found that by decreasing 1% of hemoglobin A1C, it decreased 37% of microvascular and 21% of macrovascular complication. PDE5 inhibitors, all the PDE5 inhibitors showed in a randomized control trial showed superiority over the placebo in a range of 50 to 60%. However, generally, diabetic patients required the maximum dose of each agent. Second line of management include vacuum erected device, intracorporeal injection, and penile prosthesis insertion. Thyroid. Prevalence of sexual dysfunction is high among those patients. For the hypothyroidism, it's within 60%. For hyperthyroidism, male between 50 to 77%. Presentation. In hypothyroidism, mainly erectile dysfunction, ejaculatory dysfunction, and low desire. And these two studies have shown, comparing to control, that there is a higher incidence of erectile dysfunction among those patients. Hyperthyroidism, in a study consisting of 3,200 patients with sexual dysfunction, they found that 0.2% suffer from hyperthyroidism. Inflammatory bowel disease. In a study compared inflammatory bowel disease patient to control, they found that sexual dysfunction in male patient is around 16.9% comparing to control. Erectile dysfunction is 43%. Another study consists of 69 men newly diagnosed with with inflammatory bowel disease, 39% had global sexual dysfunction, and 94 suffered from erectile dysfunction. If there is any difference between Crohn's and ulcerative colitis, results of the study are inconclusive. 64% of men and 50% of women would like to know the impact of inflammatory bowel disease on sexual intimacy at the time of diagnosis, mainly from IBD specialists, as shown in this study. What are the contributing factors? Study showed that fatigue is the main complaint for worsening of sexual life in both men and women. Psychological impact, depression, and anxiety are higher in those patients. The management, presence of a stoma, corticosteroid, and biological therapy in men were independent predictors of sexual dysfunction and inflammatory bowel disease. Here is the multidisciplinary approach was proposed by Art in his paper. It showed that sexual dysfunction should be assessed even before starting the management. A nurse should assess the sexual dysfunction. If it's available, should refer the patient to sexual dysfunction specialist. And after starting the management, if the patient started to complain of sexual dysfunction, IBD specialists should assess those symptoms and accordingly should refer him to sexual dysfunction specialist. Rheumatoid arthritis, 31 to a study showed that 31 to 76% of those patients suffering from sexual problem. A study was done showed that 53.8% of women and 45% 53% of men and 45% of women reported sexual dysfunction, mostly erectile dysfunction in men, and all the female sexual function index domain were affected in women group. Contributing factor, including physiological, which is the disease symptoms, which is include the restriction of joint mobility, morning stiffness, and pain and fatigue that could affect the sexual activity on those patients. Other contributing factors include psychological, depression, anxiety, negative body image, and worries about partner interest. And a study found that duration of the disease is highly affecting factor. They found that if the disease is more than 8 years, have higher risk of sexual dysfunction compared to less than 8 years of the disease. In a study of rheumatologists, a group of rheumatologists were asked whether they evaluate sexual dysfunction during their rheumatoid arthritis consultation. Only 12% reported doing so. At the end of the study, the author reported that sexual dysfunction and rheumatoid arthritis patient being underestimated due to the lack of multidisciplinary approach. Neurological, spinal cord injury, prevalence of erectile dysfunction 20 to 30%. Most men with spinal cord injury cannot ejaculate with sexual intercourse and will require medical assistance. 60% of female, they would have sexual dysfunction. Pathophysiology, normally we would have the psychogenic erection and the reflexogenic erection through the spinal cord. If the lesion is above the thoracolumbar pathway, the psychogenic erection will be gone. However, the reflexogenic erection will maintain the erection. If the lesion at the thoracolumbar area, both reflex will be maintained, so the patient will not suffer from the erectile dysfunction. If the lesion is below the thoracolumbar pathway, it would show that the psychogenic erection is maintained. However, the reflexogenic pathway would be gone. Lesion extending from sacral pathway to coda equina lead to an abolishment of both reflexogenic and psychogenic erectile function. As general rule, higher lesion preserve better reflex activity and greater sexual potential. Treatments, all the PDE5 inhibitors, all the agents were examined and showed success rate of the sexual dysfunction among those patients. Here in Vardenafil, a study showed that compared to control, ejaculation was success of ejaculation was achieved in 19% versus 10% of those patients. It showed that the efficacy of PDE5 inhibitor decreased with lower motor neural lesion. Spinal cord injury causal to L2 are often refractory to treatment. Here's also the other management. The literature showed that ICI, the success rate of it is 80 to 100%. Vacuum erected device showed that in the literature 70% improvement. However, there is a higher number of dropouts and choosing other modality of treatment because of the side effect of the device of being uncomfortable and there is loss of sustainability. Penile prosthesis implants, 84% of patients, they have sexual intercourse and 67 of their partner were satisfied. In a systemic review of the infection rate among those patients, it was 8%. Sacral neuromodulation was studied and it showed that 20 to 30% patients would have successful sexual intercourse. Regarding the ejaculation management, there's two ways of management. Penile vibratory stimulation, success rate 87% mainly, and it's used mainly for higher lesion. Electroejaculation, it's mainly used if the first option failed and if the lesion below the T10, success rate is 99%. Multiple sclerosis, in a study showed that, in a literature review showed that 50 to 90% of men, they will suffer from sexual dysfunction. A study showed that male most symptoms are erectile dysfunction, reduced libido, and ejaculatory problem. Mechanism and etiology for that, there is they categorize it as primary, secondary, and tertiary. Primary sexual dysfunction is a consequence of neurological changes caused by demyelination, which might affect the genital sensation, decrease sexual desire, orgasmic dysfunction. Secondary sexual dysfunction related to physical changes, including pain, spasticity, decreased range of movement, and bladder or bowel dysfunction. Tertiary sexual dysfunction is secondary to psychological and sociocultural aspects. Treatment. A study found that treatment of a bladder dysfunction has demonstrated improvement of sexual dysfunction. Other modalities include PDE5 inhibitors. Here in randomized control trial, the sildenafil improved the erection compared to the placebo. Tadalafil dosu, that tadalafil study also showed significant improvement in all the IPSS and the erectile erection and IAF and overactive bladder questionnaire scores. The second modality of management include vacuum device, intracorporeal injection on use, penile prosthesis insertion. So now we have the knowledge and we have the literature that showed that those amount of patients that they would suffer from sexual dysfunction and erectile dysfunction. How to address the unmet need? Utilize the biopsychosocial framework for managing sexual health. And we have a very good and an excellent example for the prostate cancer survivor. So a framework managing sexual health via MDs, allied healthcare, and providers such as primary healthcare, urologists, gynecologists to address loss of sexual function and aid in sexual recovery. Mental health specialists can also help to address psychological aspect, depression and anxiety, providing coping mechanism for grief, support group, which have been shown to improve the psychosocial well-being. Second is implementation science framework can then be applied to identify barriers and facilitators to provide access to care. How to address capacity limitation in Canadian healthcare through integration between the primary and specialist care, through decreasing, ideally, limit the redundancy for referrals and visits. Also, opportunity for technological innovation to assess in implementation quality of care and efficacy through automation, educational resources, personalized medicine, artificial intelligence, and more to come. Thank you so much. Special acknowledgement to Dr. Ryan Flanagan.